Yeah, so we're going to now pivot a little bit and talk about some of the resources, like putting together some of these resources for providers. And Pradeep is going to moderate this, and we have great speakers from all the different clinic types here. So I'll let Pradeep do the introductions for that.
Oh, thank you, Kay. It's really quite an honor to be able to work with this panel. Two of these folks you'll see are also past presidents of the AAP, so I've got to work with them and know them really well. One is Marsha Spitzer, who is at Family Health Centers. Her official title is Clinical Support at Family Health Centers, but the other parts that she's been our medical director for our Reach Out and Read program here in San Diego, and we have given out way more than 1 million books to kids and families. So her leadership has been great there. Dr. Pat Cantrell graduated from USC Medical School, and she did her internship up at Cedars-Sinai, and she's been here in San Diego for 20 years at Kaiser. And she's really had an interest in obesity for quite a while, including a teen and child weight management program at Kaiser, as well as being on the advisory board of the Obesity Coalition. She's also produced kids exercise DVD, Jumpstart Your Health, with her company, K Fit Health. And she, as I mentioned, she's also a past president of the local chapter of the AAP and is on our national committee and serves on national committees. In her free time, she hikes with her dog, plays tennis, and she hangs out with her husband and 2 sons. And, again, knowing her husband as well, it's another just wonderful person. And Dr. Hardisty is a pediatrician affiliated with Sharp Rees Stealy and Sharp Health here. She has a medical degree from right here at UCSD School of Medicine and has been practicing for 30 years. What I found so interesting, and I can't wait to actually hear more about this, is Dr. Hardisty's work in lifestyle medicine. And again, I just think that's a wonderful piece. She's doing that at Sharp Rees Stealy, but again, I'd love for what she's doing to get more into our community. And just before we go in, I'm going to say one thing. I'm going to tell you all it's really hard for me to refer to these folks as Dr. Spitzer, Dr. Cantrell, and Dr. Hardisty because I know them so well. But I am very cognizant that in these types of things, for women, we tend not to identify their professional credentials. Now, this is funny because I'm really known as Dr. Pradeep because Dr. Gidwani is my mom. So anyways, just a funny little piece. So each of them are going to give a little bit of a intro of what's happening in their institutions. And then we're going to dive into some questions. So please send your Q&As through the chat. And I just also want to say that we're sorry that Dr. Jeff Schwimmer was unable to attend. He had a family emergency. You might have seen that he was on there, and he's a wonderful expert on obesity. So next year we'll get him for some session. So with that, Marsha, would you mind just kicking us off and telling us what's been going on at Family Health Centers?
Great. Thanks, Pradeep, and thanks to everyone for inviting us today. So I'm just going to spend a few minutes talking about the program we have at our clinic. And so next slide. So I've been at Family Health Centers for 20 years. It's a large, federally qualified health center system in San Diego. Most of our patients live below the federal poverty line and are challenged by literacy issues, transportation, access to healthcare. Many of our patients do not speak English, so a lot of stuff going on when we're seeing patients in the office. We looked at in 2018, our rate of patients with BMIs greater than 85%, and across our pediatric clinics, it ranged from the low to high 30%. So about 1 in 3 children were facing this health issue. And our standard treatment up to that point really was for pediatricians to see patients every 3 months to talk about healthy weight management, really using the 5210 kind of framework, doing labs on kids over 10, and sometimes, but not always, referring to our health education department. So next slide. So why not keep doing what we're doing? Well, the question was, is what we were doing working? And it was a resounding no. It wasn't working for patients. Our patients' weights and BMIs weren't really changing. They didn't feel engaged in the process. And even when they were able to set a goal with us, they didn't feel like they had the tools they needed to enact the goal. It wasn't working for pediatricians. That word cloud at the very beginning with Adrian, with all those words like anxious, frustrated, hopeless, when we're seeing patients who are battling issues with obesity and overweight. That's same as we were having too. And it wasn't really working for our other services. I'm very fortunate to work for a large organization that has health education and physical therapy and mental health and a grants department. And we weren't utilizing our teams. We were each working in our own silos. So next slide. So what comes next is Healthy Together. So this was a pilot that we started in 2018. We selected 60 families from our Logan Heights branch, partially because that's where I work, and also it was our largest clinic. So 3 of us of the 6 pediatricians just started asking our patients as we were seeing them if they would be interested in this program. And what we looked for were families who were interested in making a change, who were willing to commit to pretty intensive 6 months and possibly longer, multiple visits with multiple specialists or multiple services. And we really felt strongly that it needed to be based in the medical home and in our neighborhood, because a lot of our families live in the neighborhood and we wanted the services to stay in the neighborhood. We had a large team of people who helped this happen. And so I'm not going to read them all out, but you can see the list there. And kind of the 2 keys when we got started. One was what you heard about earlier today, which was we felt really strongly that everyone who was going to be seeing patients in this program have at least a basic understanding of motivational interviewing and how to apply that to the work they were doing. And the second was we had 2 key hires. One is a exercise instructor that I'll talk about a little bit later, but really the key one was our wellness coach. So that was a new position for us. It was someone who came through health education. And this wellness coach enrolled families that were referred to the program, completed a bunch of screening tools that we had developed or had adopted for our families, helped coordinate referrals and scheduling, did some data collection, communicated with all the providers involved in care. And that was one of the key aspects of why that position was so successful, and then reinforced the education and the goal setting. I'm going to go to the next slide. So what did patients actually get? So all of our patients continued to see their pediatrician, and instead of every 3 months, we moved it up to every 1 to 2 months. They also had 2 contacts a month with the wellness coach. One of those was in person and one of those was by phone. Almost everyone went to health education and did a 7-course, about every 3 weeks, 7 sessions total. And a lot of them also were referred to our registered dietitian when they were still having questions or concerns or needs. And then we really encourage all of our families to take advantage of all 3 of the services on the right side of the screen, some more than others. So everyone was encouraged to meet at least once with our mental health department to do an assessment and see if there were any mental health concerns that might be impacting that family's ability to enact kind of weight management and healthy lifestyle interventions. Second was we encouraged all of our patients to be seen by our physical therapy team, because we know so many of the children weren't doing exercise. They lacked the mobility or the flexibility or the endurance to be able to do it. And depending on the evaluation, some of those children had one-on-one services and some children went to the last thing, which was our exercise class. So we had hired an exercise instructor. We offered 8 classes a week, 2 days a week for little kids, 10 and under, and 2 days a week for our older kids. And that was probably the most successful recruitment tool we had when we were talking to patients, was the availability with the exercise class. So some of our families did everything all at once. Some of our families did things in sequence. Some of our families did things overlapping. Some families did all. Some families just chose parts of this. And the other things that were really important to us is that everything either had to be billable or free. So there was no cost to families to participate in the program. All right, next slide. So for those of you who are more visual, this is another way of looking at it. And if I was better with PowerPoint, what I really wanted to do was put arrows between all these circles. So patients entered through their pediatrician, then they worked with the wellness coach. They got referred maybe to health education, maybe to physical therapy and exercise class, maybe to mental health. But all of us talked with each other. We would talk through our electronic health records, through messaging. We would talk through email. We would talk by phone. We would talk at our monthly meetings. And it was really important for our wellness coach to kind of have a sense of where everybody was with the different services, but it also allowed us to problem solve. So if I had a patient that I sent to the wellness coach identified there was a lot of stress eating going on, a lot of stress in the family, maybe sent to mental health, but then they never came to mental health. Mental health would come back to the wellness coach and let them know they were having a hard time engaging their family. And then maybe I might be seeing them 3 days later and I would know that. So I would be able to kind of explore with the family what the challenges were, if they understood why we were hoping that they might, benefit from mental health and what that was all about. So we were all able to kind of help each other services and help our patients understand how we worked as a team. So next slide. So things were cruising along and then COVID came along. So we pretty much went everything telehealth. So all of our health education, our wellness coach services, mental health, everything went to telehealth. Most of pediatric weight management went to telehealth. Some of my patients still wanted to come in person, especially early 2020. Most of them were too scared to come in. So we did a lot over the phone. Our physical therapy department was able to go to telehealth, which is still amazing to me. And our exercise instructor converted to Zoom. So she was able to not only host the kids that she had in class, she was actually able to host more kids because space in the exercise room was no longer an issue. And then there were even things that we were able to do that I think COVID really enabled us to do. We had always wanted to have cooking demonstrations as part of the program. And because of health and safety inspections and food prep licensing, that was really challenging. But what we were able to do during COVID is our wellness coach was able to record himself preparing a lot of really simple recipes that were healthy, things that families might already have at home or be able to easily obtain, and was able to use those videos in Zoom meetings with the families, which was great. And our exercise instructor also was able to offer one-on-one sessions with children that she saw on the Zoom screen who were struggling with the activities, maybe struggling with flexibility. She was able to offer kind of one-on-one exercise coaching with them. And I think the next slide is sort of what I would do if we had a chance to create magic wand and version 2.0, but I think I'm going to stop there because I think we're going to talk about that with the panel. So thank you.
Thank you, Marsha. It's wonderful. So next up, Dr. Cantrell and her efforts at Kaiser.
All right. Hello, can you hear me?
Yes.
All right, excellent. My name's Pat Cantrell. Thank you guys for having me here. It's super exciting. And I always am so excited when I see the San Diego getting behind this initiative. For our program at Kaiser, it's called the CATCH program, the Comprehensive Approach to Childhood Health. And next slide, please. And where this came out of, the physician's perspective is that there's inadequate time for evaluation for this really complex problem. And I have seen that a lot, and I know it's been mentioned earlier today, but this is really key. A lot is being put onto the pediatrician that you should be doing this, you should be talking about ACEs, you should be counseling the family, you should be referring, and really it's very difficult to do that. And so this is a big giant can of worms, and many pediatricians don't want to open up the can of worms, because if you don't have a good plan at your medical center or what to do with them, you don't want to open up that can of worms. So that's one of the main reasons why I thought, okay, we need to do something for the pediatricians. The referrals were being sent to the endocrinologist for early diabetes or just nutrition. They were being sent to cardiology for high blood pressure or to nephrology for high blood pressure, to the liver specialists. And they didn't have any, they just said, okay, lose weight. That was basically what they were telling them, but the patients didn't have any way to be guided to do that. And then that once they were at the specialists, they didn't have, like I said, they didn't have a program. Next slide, please. So one of the ways I got funding for this, or I got buy-in from my organization at Kaiser, because the nice part about Kaiser, it's an enclosed system, and they understand that, all right, if we can keep our members healthier, we're going to save money in the future. So one of this was a study done years ago that showed that if you have one member between the ages of 35 and 75, and they were overweight as a teenager, how much would it cost? They were able to extrapolate how much it would cost if they had diabetes, and it was $234,000 over that lifetime. And if it was heart disease, it was $526,500 from ages about 35 to 75. Next slide. So that's kind of one of the ways I got attention. I got like, okay, so what did I base this program off of? So I helped create this program based upon Dr. Barlow and Dietz, who are obesity specialists. Back in 2007, they came up with these recommendations, and it had 4 stages of intervention. Stage 1, prevention plus, that's like the 5210 in the office, mostly with the provider. Stage 2 would be more of a structured weight management program, maybe educational classes. You send them to health education, that they do some virtual classes or in-person classes. Stage 3 is more of a comprehensive program, multidisciplinary approach. And we used to have a program called KP Kids, which was a group setting, and the kids would learn, the parents would learn about healthy behaviors. They'd learn together for healthy eating. The kids would go off and, exercise. That was for kids 5 to 12. And then the Catch program sort of fits in there too, because it's more for 10 to 18. It's more of an individual approach. And so the whole program itself is called Catch, but this clinic is called the Catch Clinic, which is a sort of an individualized approach rather than a group setting. And I'll go a little bit more into that. And then tertiary care, which we're just starting to do at Kaiser right now. There's some talk about bariatric surgery, but yet we need to have the stage 1, 2, and 3 in place. So if we can go to the next slide. The way I envision this is kind of like a pyramid here. So stage 1 and 2 is on the bottom here. That's the majority of your patients. You can get them in and talk to them in the pediatric office. You can maybe send them for nutrition classes. If you feel that there's some psychological issues, you could refer to that. But many times the provider, if you don't have that, that's where I see, we can take care of a lot of patients. If stage 1 is not working in your office setting, you can go to stage 2, which would be referring if 1 and 2 aren't working, then stage 3 is more sort of sending them into a program. And not every place can do this, but this is just, when I think of this pyramid, this is my ideal thing. Like if every pediatrician could have access to the pyramid, we would be, oh my gosh, pediatricians would be just thrilled, because we just don't have a lot of time to do this in our 15 to 20 minutes with each patient. And then stage 4 is on that the very top part. Next paragraph, next slide, excuse me. So what we did is we created this Catch Clinic. And the Catch Clinic is a multidisciplinary clinic that the pediatricians can just refer and say they have to have certain criteria. We wish we could send every patient greater than the 85th percentile to this program, but we decided, you know what, we're going to have certain criteria. They need to have BMI of greater than the 95th percentile plus a comorbidity. That means that they already were pre-diabetic, had fatty liver, had hyperlipidemia, those are just hypertension. So initially, we got a lot of referrals from the nephrologist, and we still do, and from our gastroenterologist and our endocrinologist. Next slide, please. And so this is how we did this, that expert committee and how we're incorporating it into Kaiser. So here, stage 1 and 2, we have the physician office. I've given lectures and we've given information about 5210. We've taught pediatricians, these are the labs you order. And then we also have these health education classes. They've changed over the years. We used to have in-person classes, and just recently they went to webinars during COVID. So, and that's a brand new thing in the last few months. And we're hoping that way you can have, it's coming from the region. So San Diego is a part of the Southern California region of Kaiser, and there's like 14 different medical centers, San Diego being one of them. And so you can have a health educator giving a webinar and touching 500 people at once, so it's kind of unlimited, which is sort of exciting. So we have that now for kids and for teenagers, and it's a 3-session class, and it's virtual, which we're really excited about. Then the stage 2, again, the Catch and the KP Kids, I'm trying to bring that program back. That was a multidisciplinary program with the group setting, like I said. And then, like I said, the top, these are the kids who maybe were thinking of bariatric surgery, and that's just being developed at Kaiser. Next slide. So our catch clinic, which is the main thing that I run right now, it's like I said, for you have to be a BMI greater than the 95th percentile. We have an MD, a dietitian, and a psychologist, and also a case manager as a part of the team. So what happens is people come into the program, and we rotate that. It's kind of interesting. What we did is we have 9 patients in a half of a day, and there's 3 per hour. So they're in 20-minute blocks, and we stick them in like room 1, 2, and 3, and they see provider A, B, and C. And then after 20 minutes, they switch, and after 20 minutes, they switch. And each session, there are 18 topics, and they include portion size, but they include healthy families, emotional eating. We go into ACEs. We really take an individual approach. And I have to say, I think one of the most important parts of the program is the psychologist, the behavior change person. Even though, yes, every part is important. My MD, the doctor part, is I take care of the exercise, screen time, sleep, those type of things. And I deal with their medical issues if they have low vitamin D, or if they maybe, we don't always do a lot of medicines for hypertension, but we have. And first we try to do the program and see if that helps first. And anyway, they have, it's 6 hours total, but it's every 2 weeks. But what's nice is, let's say somebody can't come 1 week, then we know that they already did session 1 and session 2. They're on session 3. So they weren't able to come. They'll come, the next time we can make an appointment, either 1 or 2 weeks from then. And then we do session 3 on that. So at the end of the problem with the KP Kids program, it was a set, 6 weeks. And if people went on vacation or they couldn't come, they just missed session 4, whatever session 4 was on. And this way you can create they can get every single topic, and when they leave, they get a plan, an individualized plan of ways using motivational interviewing. Hey, how can we increase the exercise? Okay, what can we do to decrease your screen time? How can we get those fruits? It's not a one size fits all. So we like that part. All right, next slide. So our results, and these are results from the last 4 years. And we've had 420 patients that were referred, and 98 people completed the program. And what we found was and now I know that this is beyond BMI, but right now, for the sake of me getting more funding, they wanted to know what were my BMI change. That's the problem, is that we're saying, oh, it's beyond the BMI, but in order to get funding, they want to know, did your program have results in change BMI? We, out of the 12 weeks during the program, because remember, there's 6 sessions over every 2 weeks, so it's out of 3 months, 34% of the kids decreased their BMI by 0.5 or more, and about 33% increased their BMI, and about 32% stayed the same. But what is not on here, and I'm trying to have some researchers help me look at, many of the kids the BMI might have stayed the same, but their liver functions went back down to normal. Their hemoglobin A1C went from 6.2 down to 5.8 or 5.7. And then their blood pressure went down. The nephrologists love sending kids to us because we send them back with normal blood pressures. So that's something that I'm trying to capture in order to show, because the program has so many benefits. And definitely from a psychological standpoint, sometimes we identify that, hey, you know what, this family needs to get into counseling for, like we've talked about, these ACEs. And this is a stepping stone to have those psychologists do that. Next slide. And so basically, that's our program. And this is my ideal thing. I want to build a robust program so that pediatricians, we take it out of the hands of the pediatricians. They can do the beginning stuff, but to put the whole weight of this issue on them, they just cannot do it in the 15 to 20 minutes. And so I think this should be its own specialty, and have a case manager and have it. And that's my dream.
Dr. Cantrell, thank you so much. There's a lot that she brought to us that I think was really helpful, including the background information that gives us that way to make a case for it. Also, your findings are great. And I think it's going to be interesting to see of that group. It's only 12 weeks. So we wouldn't expect BMI to change that dramatically, but the results you're seeing in the lab tests are actually rather dramatic. And so I agree with you. You do realize you said the weight shouldn't be on pediatricians, and we're talking about BMI and weight. So it's hard not to have those little
That
things.
was intentional, Pradeep. That was intentional.
So thank you so much. Next up is Dr. Hardisty, and looking forward to hearing what you all are doing at Sharp Rees Stealy.
Thank you very much for the honor of being on this panel. I've so enjoyed listening to the other speakers and have been taking some notes. So yes, I'm Teresa Hardisty. I'm a Sharp Rees Stealy pediatrician. I've raised up 4 grown children who are fully functioning adults, and been practicing at Sharp Rees Stealy for about 30 years doing general pediatrics. And then in 2019, I got certified in lifestyle medicine, which the acronym American College of Lifestyle Medicine, the website I put on the chat, lifestylemedicine.org. And I guess hearkening back to medical school when I was taught see one, do one, teach one, the seeing one was really the stepping stone of becoming more knowledgeable about lifestyle medicine. And you don't even have to necessarily be certified to learn a lot more and access resources on that website in particular. But just being able to reframe my standard advice in the language of motivational interviewing, and then learning more about the 6 pillars, in fact, of lifestyle medicine, which are healthy nutrition, regular physical activity, quality of sleep, stress resiliency, building community, and avoiding risky habits. So it's been very foundational to what I was doing as a pediatrician in the first place. Eat your vegetables, turn off the TV, look each other in the eye. So when I came back from getting certified, I was able to join a committee at Sharp Rees Stealy called Be Well. And it was a committee based on wellness strategies. And I was so fortunate to be able to join this committee because we have culinary medicine, we have planetary health, we have marketing, we have administration, we have strong leadership from the Center for Health Management, which is our primarily adult-oriented, patient-facing resource. And they've been doing some foundational work already. For example, we've had a diabetes prevention program that has been up and running for quite some time, and lots of free classes. A lot of the classes are free at Sharp, even if you're not necessarily a Sharp member. So on that committee, we have been able to promote how to articulate lifestyle medicine practices into our organization. Like, how do you do it? It's like you see what you need to do, and then how do you do it? So we incorporated a health risk assessment survey that was based primarily on the health risk assessments that are done through lifestyle medicine training, and focusing on the 6 pillars. So we include stress resiliency, connectivity with community, sleep quality, etc., into our medical record now. And then knowing that one-on-one counseling with my patients, although very rewarding, has improved the quality of my practice immensely, has given me new tools to address things like pandemic-related anxiety and sleep problems. I recognize that a lot of my partners are struggling with the exact same thing. And some of them weren't even as aware of the resources that we already have. So we, through the Be Well Committee, organized some CMEs over the last year. And there was 2 of them regarding the science of lifestyle medicine, and that food is medicine. That was a whole hour, and that lifestyle is medicine, linking up some of the concepts that we've already been hearing about, how toxic stress causes chronic disease, and then how to do this in real life. How do you, we had a series of 6 1-hour CMEs. We had about 75 enrollees. On average, 50 to 60 people showed up each week for a 6-week session that ran in the spring. And we introduced the pillars of lifestyle medicine. We had speakers about stress resiliency, mindfulness. We had cooking demonstrations at each of the sessions. We had a text about lifestyle medicine that we were able to get to give to our participants. We actually had some food that we distributed to our participants so that they could make the recipes that we were demonstrating. We talked about ACEs screening. We were able to introduce the players through the Center for Health Management, which some of our participants weren't as aware of. So within the organization, utilizing the resources that we already had up and running. And then for our next goal, what we're trying to do is we are developing a shared medical appointment. So knowing that individual one-on-one counseling is effective but very time consuming. How do you scale this for a larger number of people? And so we are in the process of developing a shared medical appointment in coordination with the VIBO organization that Dr. Neeson already referred to, where we can target families, not just children, but children with their parents, to have a series of classes based on the different pillars of lifestyle medicine, with cooking demonstrations and health coaching and follow-up and incentives for them to show up. And by the way, all of this programming, including the CMEs that I was referring to, has been online now because of the pandemic. So we're trying to, in parallel, develop programming that can be given virtually or in person. And I guess the one of the other goals of the Be Well Committee is to turn that lens inward and promote wellness within our organization to our employees and to our providers. And I mean, that's especially critical in this time of the pandemic. We had a pilot employee wellness intensive lifestyle intervention class that we did in the fall of last year, based on the CHIP program. That's a complete health improvement program, which is a web-based video library support group model that has been certified by the American College of Lifestyle Medicine as an outpatient intervention. And then we are also exploring resources. We had a provider resiliency workshop that we were able to do safely in an outdoor environment, where we invited providers and their spouses to come for, we had 4 stations. We had a culinary demonstration, cooking demonstration by Dr. Neeson. We had a mindfulness expert teaching us about meditation and how to do little micro hits. We had a yoga instructor that came, and then a massage person. We had someone come teaching, kind of self-massage and what, in fact, wellness or spa-like options are available within Sharp to our employees. So I'm just very fortunate to be working with such a great team, some of whom are on this call. And we are working closely with, again, Planetary Health. We have representation from the obesity medicine department. And we're really looking forward to expanding our educational programming to our providers and to our employees, and primarily to our large patient population. And I'd be happy to take any questions. I've got my email address listed there. And thank you again for the opportunity to join this conference. And I want to give one more shout out as far as my learning journey here in childhood obesity. The San Diego Childhood Obesity Initiative has been a great resource. I'm very grateful to be part of the Healthcare Advisory Board, and I think that the resources and the connectivity and the network that you're promoting is really foundational to all of what we're trying to do here. So thank you very much.
Well, thank you. I mean, that was just Dr. Hardisty. That was a wonderful presentation. And again, adding some context and adding layers to this work. And I think of this work with our Adverse Childhood Experiences Committee, that the lifestyle medicine is really some of the prescriptions we give there as well. So a lot of overlap and a lot of great potential. Speaking of questions, let's go around and do questions. And since we're with you, let's start with you, Dr. Hardisty, and start out with a question. What have you learned that you can share and how to make this program a success? Like how to make these programs a success? You've done a lot to make the program a success. So what advice would you give others who are trying to start something like this in their setting? Because you've really been on a journey.
Yeah, I think that getting allies, people that are interested, at your side, even if it's just your doctor that works down the hallway, or your nurse, or a sympathetic person in administration, or a cardiologist that, runs marathons, or, find who your tribe is and then work together with them, because I think that that's one key. And then the second thing is know your audience. So when we've been developing some of this programming, is it the doctors themselves? Is it the staff? Is it the patients? And then that will allow you to develop your programming and be more effective. So getting allies and then being directed, because there's just such a large responsibility, it's a big nut to crack. And so you have to take it in stages. And the SMART goals that we've been recommending through lifestyle medicine as part of the kind of motivational interviewing process is I have to take myself, like, what is the small nugget of something that I can do that, will push this boulder up the hill.
Great, thank you. So we'll go around to each of the panelists and we'll come back to you for another question in a moment. But Dr. Spitzer, same question. What advice would you give about how do you make these programs a success?
I'm going to echo what Dr. Hardisty said. Like, it is a team effort for sure. Like, you can have the most motivated pediatrician in the world, but if she or he doesn't have a team of people who believe in the process, it's really hard to get anywhere. So play well with others, definitely important. Talk to other people. I mean, we found allies in funny places. Like we have one of our referral specialists, manager, people in our pediatric PT department has been fabulous in looking for tweaks that we need to make life easier for everybody, right? So not the first person I would have gone to thinking, oh, of course, you're going to be an ally in our pediatric obesity program. That's huge. And I think the other thing is, and Dr. Cantrell kind of alluded to this, finding a way to count the successes that doesn't focus on BMI, which is really hard because that's what every funder and administrator, it's the easiest thing to measure. But I think for us, celebrating the wins that were not BMI based at all. And I'll just, say as one example, with our very first cohort, we had 2 families where the dads of both families had changes in their health. One was a dad who went to his appointment, had high blood pressure, and his doctor asked, what are you doing different? Because we are going to start taking you off your blood pressure medicine or lowering it. And another one was a similar dad who had just been along for the ride, right? His family was making these changes and he went along with them, and his hemoglobin A1C dropped. So he was a diabetic and was able to also go down on his medication. So those are huge wins that wouldn't show up in any data analysis of BMI or number of visits. But to me, like, celebrating those and finding a way to measure those or recognize those, incredibly important.
Thank you. Thank you. So Dr. Cantrell, I'll ask you the same thing. Like, what would be your advice about how to make these programs a success?
So a few things that is very common with a lot of these patients that are in this program, this is not necessarily something that's high on their list of wanting to do. I mean, go back to like, are they really motivated to do this or not? So you want to make sure there's no barriers for the patient to have access. So in our program, one of the first barriers that we had, for some reason, they did like a 3 copay thing because they were seeing 3 different providers. And that, if the copay was $30 for our patients, that's $90 a time. That was a barrier. I was able to get rid of that barrier and make it down to 1 copay, which, is either $10 or $30, something. And that's definitely much more. And some, if they're Medi-Cal, they don't have any cost at all. But that's huge. It's making sure that it's they can pay for it. Second thing, access for the patients, because if you have a program like this and it's at 9 o'clock in the morning and you have to pull the child out of school, parents aren't going to want to do that. So what we've had to do is shift the appointments to the afternoon. Like our Wednesday clinic is 3 to 7, and our Friday clinic is still 1 to 5. But ideally, afternoon appointments, and this has been shown to when you're trying to do a program like that, take that into account. And then if you have a program like this, being able to coordinate it. Luckily, I'm in a closed system. And so is Dr. Spitzer. But it's and I think depending on where you're at, do you have a health education department that you can work with? Do you have a psychology department? Are you able to put that together? And if you're not, it's kind of hard. And so, I mean, again, in the perfect world, I would love if in the county we had some program that the pediatricians that are in smaller practices could refer to, to be able to coordinate something like that. So you do need to have somebody who's motivated, and I echo both other doctors, the other physicians on the panel saying that you need to get that team and get buy-in and get your champions together. So yeah, I'm trying to think about that. Yeah, let me think. And then when you do the program, you have to get multiple people to do your program. You can't just have one doctor, one nutritionist, and one psychologist. You have to have multiple because people go on vacation. And so these are just things logistically to think about when you're trying to put something like this together. And of course, funding. Where is your funding coming from?
Yeah. You did a wonderful job answering that. And let's just stick with you for the question of, are there other barriers that have come up? Because you really identified some very critical barriers if you don't think through.
I think that let me try to think. I think having I could call this a learning, is having somebody be a good coordinator of this program. It's essential. I have seen these types of programs being put on the back of one physician who in their spare time needs to call the patients and make sure that they come, and we just don't have the time to do that. So unless you're given the time, I guess, to do that, but to have somebody who is a dedicated coordinator is extremely important. And I'm trying to think also this patient population has a high no-show rate. So we actually have a way in our system that we slightly overbook it, knowing it, even if everybody shows, which is very, very rare, we can still handle the program, but we sort of, our full appointments are 7 in a half day, and we book for 9, and we often get 5 or 6. That's pretty typical, even though we call them the day before and they said they're coming. Right. So the barrier is, patient no-show rate is very high in this group.
I do think this piece of participation becomes so challenging. My co-host is quite vigorously protesting something. So Dr. Hardisty, could you speak a little bit to what barriers and obstacles you've had to overcome in getting things implemented?
Yeah, yes. I mean, I'm going to echo what we all know, which is time. That is a huge barrier. And, I think that trying to stay in line with what we're doing for ourselves with self-care, there's this balance that we try to strike. And working, full time in the clinic, and then adding, even 1 minute more per patient, or an hour more for a meeting, or for a webinar, or for a meeting on the day off, like that is the big challenge. And I'm not sure if I have an answer to that yet. I think that advocating for lifestyle medicine type programming within an organization, and then valuing that enough to put resources into it, or to get grants, is certainly an option that I want to continue to explore. But for now, you get what you bill for. And so I think that it's a big juggling act.
Absolutely. And Dr. Spitzer, what obstacles and barriers have you had to overcome to make things work?
When we started out, we had a very set, fairly rigid kind of, we're going to do this for every patient, and then this, and for this. And what we found is that it can't be one size fits all for our population, or for what we wanted to do. We're not a research institution. We had these grand ideas. We were going to collect all this data and do all this evaluation, but we realized that may have been serving our needs more than our patients. So letting go of some of the structure, and kind of really meeting families where they were. And for the families who really wanted to engage on health education, but really were resistant to mental health or physical therapy, just letting them get there if and when they wanted to, and just sort of letting each family decide their course and their journey through the project. I think the other thing was trying to make things as cost neutral as possible. So, most of my patients are Medi-Cal, so copays are not an issue for us, but getting services paid for by Medi-Cal was. So we were creative, for example, with our exercise classes. We can't bill for those, or at least if we can, we don't know how. And so our physical therapist would use that time. Often the physical therapist would do like a 15-minute intervention with 2 or 3 children during the exercise class. So he would, in the physical space, he actually had a little corner where he would bring kids and do a quick brief intervention. In the Zoom world, he uses a breakout room. And so that was a way for us to be able to have a qualifying physical therapy visit during a unqualified, or whatever finance would call it, exercise class. So having to be creative and look at ways that we could make services as cost neutral as possible, certainly for patients, but then also for the organization, was important.
And Dr. Spitzer, let's stick with you on this next question, which is, I know you've been doing this for a little bit. I don't know if you have like how people are doing after the program finishes. Are you able to kind of comment to what happens after they finish?
No, that's a good question. So we were able to analyze kind of after about 9 months where patients were, and again, this was before COVID. Our numbers fairly similar to Dr. Cantrell, right? The 30 kids, if you just look at BMI, 30 kids went up, 30 kids went down, 30 kids stayed the same. Mm-hmm. But if we measured lifestyle changes, again, anecdotally, about 40% of the patients in the pilot were my own patients that I was seeing, and the lifestyle changes were much bigger. Like those were the things that we could see. Now, over the long haul, we haven't followed patients all the way out. So it's a good question to which I do not have an answer.
But again, your system is also relatively closed, and you have people who stay with family health centers. So it could be an interesting follow-up. Pat, or Dr. Cantrell, you have a great opportunity because of Kaiser being a closed system. What kind of follow-up have you been able to do, and what do you see happen over time with the families?
Yeah, that's perfect. That's a great question, because what's interesting is if you just drop them off at the 6 sessions, the 12 weeks, then you will see some of those patients gaining the weight back. They do seem to need that support. We have about 2 to 3 follow-up sessions. Some families want to come back 5 different times, and those follow-up sessions with us are about every 2 months. But what's very interesting, there are some families, some teens where I have seen we at the follow-up, they did so during the program, but then afterward they just figured it out, and then bam, they really changed their lifestyle. And so initially, again, this is not just BMI, you know, but maybe you saw the lab changes and you like, okay, they seem to be doing the right thing. BMI is kind of similar. And then after like 3 or 4 months, they all of a sudden the weight just comes off. It seems like their lifestyle changed. They became less stressed, and it all sort of fell into place. Again, not concentrating on that part, but there are some families that if you don't have the support, they do fall. There's a recidivism. What's that word? Where they recidivism? What's the word I'm looking for?
Yeah. You know, you're
yeah.
So, Dr. Cantrell, great points. And I think that's the interesting thing. As we build these programs, we have to think about what level of support goes on. But as Dr. Spitzer said, there's that flexibility too, right? Because the one size doesn't fit all. And, our family is ready, and then do they have the capacity to make those changes? So that's really good insights. Dr. Hardisty, do you have any insights on how folks do after they finish with the actual interventions?
Yes, and that's more just based on not research, but my own patients who I've been working with over the last several years. And I love the comment about the dad's A1C dropping, because I've had parents come in, I counsel a toddler. They're just there for their 4-year checkup, and I give them ideas about healthy nutrition. Obviously, it's part of the normal conversation. And I literally have had parents come in for like pink eye, 6 months later, and they're like, wow, I just want to thank you. I've lost 10 pounds,
Yeah.
And the kid, meanwhile, was not overweight in the first place. So I think that just letting people know that these are important issues, like how often do you wake up tired? How do you feel supported? Do you feel like there's people you can count on in your life? How do you manage your stress? Like, those are all questions on the health risk assessment that is in our medical record now. And even if you just ask one question and you don't even talk about nutrition, what you're letting people know is that these issues are important to you, the doctor, and that they affect your health trajectory, and not just for your child, but for your family. So I think that just opening the conversation is an intervention in itself. And I think that, over the course of time, one of my goals is to look at healthcare dollars spent, and, to the number that you were using as a motivator for opening the program over there at Kaiser.
Yeah.
I think that looking at healthcare dollars spent from the patient's point of view and from the health plan's point of view is a whole nother way of looking well beyond the BMI that might be helpful as far as gaining traction in this, way of providing care.
Thank you. That's wonderful. And again, the different systems allow us to look at that, and the piece of, seeing that change in parents is amazing. And a lot of times, the intervention being at that family level becomes, such a ripple effect. We have about 4 minutes left, and so I just wanted to give the panelists. Oh, that's a good question. I wanted to give the panelists a last word. A chance to get a last word. I myself know that I've learned a lot, so I don't know if you want to reflect on a last word or something you learned from your colleagues today. So Dr. Hardisty, we're with you. Is there anything that pops for you?
I want to say that this line of practice, this lifestyle medicine approach that's in parallel with my pediatric practice, has greatly improved the quality of my life. So rather than stressing me out that there's one more thing I need to do, it's really empowered me to be a more effective provider. And that's one, important thing that I would like to share with everybody.
Oh, that's wonderful. That's beautiful. Dr. Spitzer, is there something that you've learned today or a last word that you want to add?
So similar to what Dr. Hardisty said, I personally used to dread these visits before we did Healthy Together. They just never were fun, right? And I think the one thing that I've changed the most, even in my patients who are not Healthy Together patients, which is the majority of my patients, is that like, I don't talk about the BMI at all anymore, actually, or the change in BMI at all. When I'm seeing them for weight management visits, we just talk about how things been going. You know, COVID's nice because it's not nice, but the lens of COVID has made that easier because, you know, how are things going for you guys? How are you handling, you know, changes in food availability, physical activity opportunities, stuff like that. And just talking about change, like what changes have you been able to make? What changes have just cannot happen right now because we can't join a soccer team because the rec center is closed, or, you know, stuff like that. And so we just talk about changes instead of the number. And sometimes I don't even get to the number. And sometimes parents don't ask either. And that is so liberating. It feels so much more fun to do those visits now and focus on positive changes and problem solving the changes that have been challenging instead of looking at a number and, you know, fretting about what direction it's going. So I would encourage people as much as you can to truly embrace the title of the workshop, right? Really go beyond BMI if you can.
Nice. Thank you so much. And Dr. Cantrell, last words, anything that you learned? What would you like to close with?
Yeah, I'd like to say that I think that we know a lot on how to take care. A lot of people say, oh, these kids we don't know what to do with them. We don't know how to treat childhood obesity or how to help these kids in this situation. And I don't think that's true. I think we know a lot. And I think this virtual conference has shown we know what we need to do.
Wow.
We just need to implement it. Okay. And that's I don't know how we can get the buy-in from the people who have the money. And just like these expert committee recommendations, they came out in 2007. What is that? 15 years ago. Okay. And we're still having, it really does work and it can be done, but it's just not being implemented. And in the context of those expert recommendations, we can add the ACEs and the Beyond BMI into that. And we can do it. I just think we just have to, it's a marathon. This is not a sprint. We're all in this, and we just have to keep our, head to the grindstone, or whatever it is that phrase, we just have to keep at it. And I think we're going to get there, but just, we know how to do it. We just need to do it.
I honestly couldn't think of better ending remarks, Dr. Cantrell. That was beautiful, wonderfully said. And I think a paradigm shifter of saying, we can do this. We know what works. Give us the resources. We'll get it done. And all of you showed how you can get it done in different organizations. And there's some similarities, there's some differences. And really at the heart of it is the great effort, dedication, and care. It's been such an honor to moderate this. I'm going to pass it back over to Kay, and I want to thank all of our panelists for just an amazing opportunity to learn from you. So thank you. Thank you very much.
Thank you.
Yes, thank you all. It was really illuminating to hear how you guys have worked the system to get to do these programs. So I'm hoping people took something away from this.